This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014.
We're going to turn our discussion to thyroid pharmacology. And before we talk about the actual drugs, we'll just give a little bit of background as to what thyroid hormone is, where it comes from, what it does, and why it's important. And then we'll talk about, obviously, the different drugs involved in treating diseases of the thyroid, whether those are diseases in which the thyroid is overactive, also known as hyperthyroidism, or diseases in which the thyroid gland is underactive, which would therefore be known as hypothyroidism. And so the thyroid gland secretes several types of hormones. The thyroxine hormone, also known as T4, smaller amounts of the triiodothyronine, also known as T3. And these T4 and T3 hormones are involved in the regulation of important things such as growth and development, maintaining body temperature, playing a role in control of cellular energy turnover. So these hormones are essentially important to the organism and its functioning, and we will see the consequence of too much or too little of those hormones and why hormone replacement therapy or antithyroid therapy might be warranted. In addition to T4 and T3, the thyroid gland secretes another type of hormone called calcitonin, which is involved in the regulation of calcium. And this hormone is something we'll talk more about in the osteoporosis lecture after the midterm. Now, the thyroid gland will produce thyroid hormone upon stimulation. And remember, we're in the endocrine section of drugs and disease, and everything we talk about is going to relate to the endocrine system. And in the endocrine system, obviously, as you've heard already, there's tight control of the secretion of different hormones, and obviously that's in the best interest of survival, because you wouldn't want these hormones to be produced in excess or in deficiency. And so the body has evolved a way of tightly controlling the synthesis and release of different hormones. And so in terms of the thyroid, one of the major players is the pituitary gland. And the pituitary gland, upon stimulation from which brain center? That's right, the hypothalamus. Upon stimulation from the hypothalamus will release a hormone called TSH, or thyroid stimulating hormone. And that hormone is going to travel through the circulatory system to the thyroid, where it will bind to TSH receptors. And upon activating those receptors, the thyroid gland will start to synthesize T4, or thyroxine. Now remember, the thyroid gland produces different types of these T compounds, right? We have T3 and T4. There's also something called reverse T3. But among all those analogs, T4 is the one which is produced most abundantly by the thyroid. And so that T4 is going to be released from the thyroid gland, and it's going to have impact throughout the body, in particular controlling cellular energy, but also other effects, such as those we referred to in the... Now, when we talk about thyroid hormone, we think about iodide. And iodide is the elemental form of iodine, right? Iodine would be I2, right? That would be the element. Iodide is the ionic form or the anionic form. And when we look at iodide, it's essentially taken up through our diet, from food, from water, or from medicines. Certain medicines contain iodide, which can increase the iodide pool in the body. Now, the recommended daily intake of iodide is about 150 micrograms a day, and that increases during pregnancy. And that iodide, once ingested, is well absorbed, and it will be taken to the thyroid gland, which is very good at removing the iodide from the blood. It's very good at accumulating it within that thyroid gland. And in fact, that was one of the big concerns with Chernobyl, which was that big nuclear disaster in the Ukraine that had a serious impact throughout the Ukraine and other countries because of the release of a radioactive form of iodide that could be accumulated in the thyroid gland and obviously contribute to destruction or increase the risk of thyroid cancer, which persists even till today, an increased risk in the Ukraine. Okay, so anyway, getting back to the iodide, thyroid gland is going to remove about 75 micrograms a day from the blood, which that has gotten there through absorption through food or water, and the balance of the iodine is just excreted in the urine. Now, once taken up into the thyroid gland, the iodide goes through a series of steps to convert it into active thyroid hormone. Now, the process by which the thyroid gland removes iodide from the blood is called trapping. Right? That's called iodide trapping. Right? So the thyroid gland has removed the iodide from the blood. That iodide gets oxidized to iodine by an enzyme called thyroidal peroxidase. Okay, so this is an enzyme that oxidizes iodide back to iodine. And that iodine is going to interact with tyrosine residues within thyroglobulin to form different types of chemical structures. The MITs, the monoiodotyrosines, and the DITs, the diiodotyrosines. Okay, so this process of taking the iodide, oxidizing it, and adding it to tyrosines within thyroglobulin is called iodide organification. Now, there's an enzyme involved, thyroidal peroxidase, in this organification step. And that enzyme is a target of certain anti-thyroid drugs, particularly thioamides, which we'll talk about later. Okay, so this is going to be a kind of drug you use when the thyroid's too active. In order to produce the thyroxine, 2 molecules of DIT, diiodotyrosine, are going to combine on the surface of the thyroglobulin molecule. Remember, this is the coupling reaction, which is also mediated by thyroidal peroxidase. So remember, thyroidal peroxidase has two activities. The first is adding the iodines onto the tyrosines by organifying, through the organification reaction, oxidizing the iodides to iodine and adding those to tyrosine residues. And then the second part of the reaction is a coupling reaction, combining 2 molecules of DIT or 1 molecule of MIT with 1 molecule of DIT. Excuse me. When you combine 2 molecules of DIT, you form thyroxine, T4. When you combine 1 molecule of MIT with 1 molecule of DIT, now you have 3 iodides on the molecule, you have T3. So now, this is all still present on the thyroglobulin molecule. And in order for the thyroid gland to release T4 and T3, those hormones have to be removed from thyroglobulin and put into the circulation. And the way that happens is through exocytosis and proteolysis. First of all, the the colloid material within the follicle will pinch off into the follicular cell and fuse with a lysosome, which is going to cause that lysosome to release its toxic contents, which contains proteases, enzymes that can cleave off the T4 or the T3 from thyroglobulin. And once that occurs, that hormone is now free and can be released into the blood. Now, the monoiodotyrosine and the diiodotyrosine, which is released following the internalization of colloid and the cleavage by proteases. Remember, some of what gets released is thyroid hormone, and some of what gets released are these precursors. Well, these precursors will be deiodinated within the gland. The iodine will be reutilized or recycled. It's important to note that when it comes to the ratio of T4 to T3 within the thyroglobulin itself, right, that's the scaffold upon which the thyroid hormones are built, that ratio is about 5 to 1. Some textbooks might say it's 4 to 1, some textbooks might say it's 4.7 to 1, but within this area of 4 to 5, definitely many-fold higher T4 levels on any given thyroglobulin molecule than T3 levels. So most of what will be released is the T4, or the thyroxine. Remember, the T4 is going to still be further metabolized outside the thyroid into T3 quite often. Remember, T3 is the active form of thyroid hormone, but much less of T3 is released from the thyroid gland than T4. So most of the T3 that's actually found in the circulation occurs as a result of metabolism of thyroxine and loss of that fourth iodo group to form T3. Tyrosine, again, is a critical amino acid in the biosynthesis of thyroid hormone. Tyrosine will be modified in different ways and linked together in different ways to form T4, known as thyroxine, or by its chemical name of L3,5,3', 5', tetraiodothyronine. Right, that's the chemical name for T4. While a common name for T3 is triiodothyronine, or chemical name L3,5,3' triiodothyronine. And so when you look at these thyroid hormones, they're basically two tyrosine residues linked together, but the critical point is that those tyrosine residues have been iodinated. And so if you look at the left structure, you see the structure of tyrosine. If you look at the next structure to the right, you see the structure of thyroxine. And what you really see is tyrosine plus the phenyl group of another tyrosine, right? So it's basically like 1.5 tyrosines that have been modified with 4 iodides, hence the name T4. When we look at T3, we could either achieve triiodothyronine, where the iodo group is lost from the outermost or the uppermost phenyl, or from the ring closest to the hydroxy on the tyrosine, the terminal hydroxy, or we can lose the iodo group from the inner ring, the ring closest to the amino side. Where we lose the iodo from the outer ring, we get the active compound T3. However, when you lose the iodo group from the inner ring, that closest to the amino group, you get an inactive form of T3 called reverse T3. Now, a large majority of the thyroid hormone released from the thyroid gland is T4. But remember that T3 is the more active form pharmacologically. And again, we talk about synthesis on thyroglobulin. Most of what's made there is T4, but yet T3 seems to be the more pharmacologically active form. And indeed, most of the T3 circulating in the body occurs not because of direct release from the thyroid, which can certainly do that, but really from the metabolism of T4 in peripheral tissues such as the liver, the kidney. And so we can deiodinate T4 to give us the active hormone, or to give us the inactive hormone, reverse T3. So now these thyroid hormones are made, they're released into the blood, and what we know is that they're very poorly water soluble. In fact, more than 99% of the T3 and the T4 in the blood will be bound to a carrier protein. And the principal carrier protein, the chief one, is TBG, thyroxine binding globulin, TBG. So thyroid hormone has its really own special carrier protein called TBG. And just to put things in perspective, only about 0.04%, right, 0.04% of the total T4 that's released by the thyroid gland is actually free and not bound to TBG. Very small percentage, 0.04%. It's almost basically what they pay now on your savings account in the bank, 0.04%. Barely anything. A very small fraction is free. In terms of T3, it's a little bit higher, but still very small, 0.4%, bound to TBG. So what this information tells you is that when the thyroid hormone is released from the gland, most of it gets bound to protein in the blood, TBG. A very little bit of it is free, but that very little bit is the part that goes into target tissues and elicits pharmacologic responses. So as you can imagine, a disease state that would affect TBG levels would affect thyroid hormone effects in the body. So just to review, the recipe that one would use to produce thyroid hormone would be tyrosines and iodine. The tyrosines come to us from that glycoprotein in the colloid space called thyroglobulin. Remember, thyroglobulin is an excellent source of tyrosine. There's over 130. In fact, there's 134 tyrosines in this protein. Okay, many of them will serve as the site of thyroid hormone synthesis. The other thing the body needs to make thyroid hormone is iodine. Now, most of the iodine that your body brings in is from the diet. You get it from iodinized salt that you put on your french fries, or you can get it from seafood. There's certain other foods that are rich in iodine. You can get it from supplements. And so iodine is brought in from the diet, and in fact what's usually absorbed is the ionic form, the iodide, I-, which gets taken up from the blood by the thyroid epithelial cell. And those cells have a transporter on their surface called the sodium iodide symporter, which brings iodide in. Remember, the thyroid gland is excellent at trapping iodine. Okay, this is the primary place. If you're looking for iodine in the body, you're going to find it in the thyroid gland. And so we'll talk a little bit about, how the iodide and the tyrosines meet and how we actually make thyroid hormone in a little while. So if you look at the middle portion of this figure, you see like a red squiggly line, 3 panels. Sticking off that red squiggly line are tyrosine residues. And the magical thing about tyrosine residues is that they have a para-hydroxy group, right? So you can see it right there, and that tyrosine is going to be the source of iodination, right? So iodide gets into the thyroid gland, it gets converted to iodine, it gets added on to tyrosine residues within the thyroglobulin molecule, right? So if you look at that squiggly line in the left panel, you can see that the iodides will be placed on to the phenyl ring to form diiodotyrosines or monoiodotyrosines, and adjacent tyrosines that contain the iodides can be linked together to form the thyroid hormone, still bound to the thyroglobulin, which is the rightmost panel. So if you look at this, it's really a two-step process. First, putting the iodines onto the benzene ring in these structures. The second is to fuse the iodinated phenyl ring of one tyrosine to the other tyrosine to form the active thyroid hormone, which is what you see in the right panel, to form thyroxine. And so the thyroglobulin serves as the site of tyrosines. The tyrosines get iodinated, and then there's a coupling reaction in which the tyrosines get linked together to form the active thyroid hormone. The enzyme that makes this happen is called thyroidal peroxidase. Sometimes it's abbreviated as TPO. And that's actually going to cause the addition of iodines to tyrosines. Sometimes that's called the organoification reaction. And the second step is going to actually be to link the two iodinated tyrosines together. So as drawn here, you see the linkage of two diiodotyrosines to form thyroxine. It's also possible, however, to have a monoiodotyrosine, not pictured in this graph, linked up with a diiodotyrosine, which is pictured here, to form T3. And depending on where the iodine is lost, whether it's on the inner ring or the outer ring, you can have the active thyroid hormone T3, or you can have the inactive hormone reverse T3, as we talked about in a previous slide. And so now we've built our thyroid hormone on the thyroglobulin, but the thyroglobulin is a big protein, and the thyroid hormone needs to leave the surface of that protein and get into the bloodstream. And how does that happen? Well, it's a multi-step process. Okay, first, the thyroglobulin will be brought into the thyroid epithelial cell through the process of endocytosis. Some of that colloid will be endocytosed into the thyroid epithelial cell. And that colloid contains thyroglobulin. So there will be some colloid that contains thyroglobulin, and some of that thyroglobulin is going to contain thyroid hormone. So what happens then is once that colloid has been endocytosed, it can actually, that endosome can fuse with a lysosome, and that lysosome is going to contain proteases which will digest the thyroglobulin and free up the thyroid hormone to now diffuse into the blood. And so the free thyroid hormone will diffuse out of the lysosomes through the plasma membrane and into the blood, where it will bind to its carrier protein, TBG, and be transported around the body and have effects in target cells. Right? So this process that I've been discussing is depicted for you here. In the upper left panel you can see the colloid space indicated in the pink area, and you can see the iodinated thyroglobulin. Okay, the green specks on the thyroglobulin would depict molecules of DIT or MIT. I'm sorry, actually that's the thyroid hormone already made. Right, so those green specks are the thyroid hormone already made. And so that colloid containing thyroglobulin that contains thyroid hormone on its surface can be brought into the cell through endocytosis. As you can see, a lysosome will then fuse with that endosome to degrade the things within it. And as that occurs, free thyroid hormone will be liberated from thyroglobulin and be able to diffuse into the blood. In the right panel we have some reference serum levels of T3 and T4. Remember that although, for example, T3 levels in the blood range from 80 to 150 nanograms per deciliter, the amount of free T3 is much less because of high binding to TBG. And so, whereas normal serum levels are 80 to 150 nanograms per deciliter, the free levels are much less, 0.14 to 0.35 nanograms per deciliter. The same can be said of thyroxine or T4, where normal serum levels are 5 to 10 micrograms per deciliter. However, the free levels of T4 range from 0.7 to 1.86 nanogram per deciliter, much less. Okay, and if you look below the right panel, the right side of this figure, lower panel, you see some histology of a thyroid gland with arrow pointing to the colloidal space where the thyroid hormone is synthesized. So to summarize, there are several steps that are worth familiarizing yourself with in the process of thyroid hormone biosynthesis. These include iodine uptake, the organification reaction where iodine is added to tyrosine to form MITs and DITs, then the coupling reaction where an iodinated ring is removed from MIT or a DIT and added to DIT to give you either T3 or T4. Then we talk about endocytosis, degradation through the lysosome, and release of thyroid hormone that can actively bind thyroxine binding globulin in the blood. Alright, so that T3 and T4 that get eventually released from the gland into the blood will bind to TBG, most of it, and some of it will be free, but a small fraction. And any MITs or DITs that hadn't yet formed thyroid hormone but were endocytosed and exposed to the lysosome, the iodide will be recycled. So this process generates T3, the active pharmacological form of thyroid hormone, also known as triiodothyronine, forms T4, thyroxine, and we can form reverse T3, which is an inactive compound. Thyroid hormone has many target tissues. What makes these target tissues similar is the site of the receptor for thyroid hormone, and in all cases thyroid hormone receptors are not cell surface receptors but are rather nuclear receptors that can affect gene transcription. In fact, thyroid hormones are critical in the control of cellular energy transfer. The use of oxygen and water and other substrates are consumed, and thyroid hormone helps the body produce heat, carbon dioxide, and energy. So very important functions of this hormone in the body. This is a slide that depicts some structures of the compounds I've mentioned in the preceding slides, as well as their half-lives and how much of each form is made per day by the body. And so if we look to the very top of this figure, we see monoiodotyrosine and diiodotyrosine. These are the precursors, the thyroid hormone. And below we see T3, T4, and RT3. In T3, the iodo group that's been lost is on the furthest benzene ring away from the amino terminus. Right, so in T3, the iodo group that's lost is farthest away from the amino terminus. In reverse T3, the iodo group that's lost is closest to the amino terminus. Okay, do you see that? The iodo group in T3, which is lost, which is here represented as a hydroxy group, is the furthest away from the amino side of this molecule, while in RT3, the iodide that's lost is actually closest to the amino side of the molecule. In between, we have T4, two DITs linked together. The benzene ring of one DIT with regular DIT linked together. Now, in terms of half-life, T3 has a half-life of about 20 hours. Some textbooks will even put it up to 2 days, but most textbooks will refer to it as about a day. The half-life for T4 is on the order of 7 to 10 days. And in terms of RT3, we don't consider its half-life because it's an inactive compound.
Peripheral metabolism of thyroid hormones. A small amount of thyroxine is biologically inactivated by reactions such as deamination, decarboxylation, or conjugation and excretion as glucuronide or sulfates. The primary pathway for the peripheral metabolism of T4, however, is deiodination by the enzyme 5' deiodinase. Well, there are other types of deiodinases, but the one that's mostly responsible for thyroid hormone effects is the 5' deiodinase. So deiodination of the T4 may occur by monodeiodination of the outer ring, which produces T3, the active compound, 3 to 4 times more potent than T4, or deiodination can occur in the inner ring, giving you reverse T3, which is biologically inactive. So really, the enzyme responsible for biologic activity of thyroid hormone is the 5' deiodinase. And so drugs such as ipodate or beta blockers, corticosteroids are known to inhibit 5' deiodinase and can precipitate low T3 levels. The numbers here below are typical normal values, approximates, of what the thyroid gland produces daily. And so here we've got about 75 micrograms of T4 and about 5 micrograms of T3 per day. And that 75 micrograms of T4 gets converted to about 25 micrograms of T3 and about 35 micrograms of an inactive, RT3. So typically, the thyroid gland is generating about 30 micrograms of T3 daily, plus or minus a few micrograms. But that's in the normal situation. Okay, remember that when that T4 is becoming active T3, it's going to be deiodinated by the 5' deiodinase. And there are certain inhibitors of that enzyme that we're going to discuss shortly that can produce a hypothyroidism, an impaired formation of T3.
In this slide, we have several targets for drugs that can affect thyroid. Those targets are pointed to by red arrows. And so as you can see in the upper left corner, we have a red arrow pointing to the sodium iodide symporter, which is present on the blood or the basolateral side of the thyroid epithelial cell. And so that iodide, which comes in to the epithelial cell, will be further transported into the colloid space, where that iodide will be oxidized to iodine, organofied on tyrosine residues, coupled with the base being thyroglobulin, and the enzyme responsible for that synthesis is TPO. So in this figure, TPO stands for thyroidal peroxidase. If you look a little bit to the right of that, you see TG, that stands for thyroglobulin. And of course you see in this example the thyroid hormone docked down on thyroglobulin. And so all of that's going to be produced when iodide comes in to the colloid space, gets organified, gets coupled, and now we have thyroid hormone formed. If we look a little bit down on the slide, about 5 o'clock, we see the internalization of some of the colloid material, this little blue circle that's forming and fusing with the lysosome, to now release molecules of T3 and T4. Of course, predominantly what's released is T4. So if you look down at the T4, you'll see another arrow which can block the conversion of T4 to T3. And remember, that's going to happen in peripheral tissues such as liver, kidney, other peripheral tissues through the action of an enzyme called 5' deiodinase. So this slide shows you different drugs that can affect some of these different targets. There are drugs that can affect the sodium iodide symporter. There are drugs that can affect thyroid peroxidase. There are drugs that will affect 5'-deiodinase. In all of these instances, what is the effect of the drug going to be if you block thyroid peroxidase or if you block 5'-deiodinase? Yes, you're actually reducing the effect of thyroid hormone, right? So those will be anti-thyroid drugs, and we'll discuss them briefly. However, before we go there, just to orient us to kind of the whole endocrine axis, the story starts in the hypothalamus, which releases TRH, also known as thyrotropin-releasing hormone, to the anterior pituitary. When TRH gets to the anterior pituitary, it binds to receptors and stimulates the release of TSH, which is thyroid-stimulating hormone. The TSH is going to stimulate the thyroid gland to produce thyroid hormone. And there is the presence of a negative feedback loop in which both T3 feeds back on both the hypothalamus and on the pituitary to shut off release of TSH. So if you look a little bit down below TSH, you'll see what's labeled as the TSH receptor. Okay, so this normally is going to stimulate production of thyroid hormone when activated by TSH. But there's actually an antibody that is produced in some people that actually binds to that receptor and stimulates it as if it were TSH. And that disease is called Graves' disease, and it's relatively rare, not extremely rare, but relatively rare. And basically, in that situation, the patient's making too much thyroid hormone. And of course, the thyroid hormone has effects all throughout the body. We see T3 receptors in all areas, places such as skeletal muscle, heart muscle, bone, liver, as well as other sites, brain. So, making sure that the thyroid pituitary hypothalamus relationship is healthy is a good way of ensuring that the thyroid gland is healthy, as it's an important part of that relationship. So we'll begin our discussion of the basic pharmacology of thyroid and antithyroid drugs. First we'll start with thyroid replacement, thyroid hormone replacement, which is giving back thyroid hormone. In terms of pharmacokinetics, the data on or with respect to pharmacokinetic parameters has really been derived from the administration of exogenous hormones back to patients. For example, we know that T4 is absorbed best in the duodenum and the ileum, and that its absorption can be modified by intraluminal factors, things that can affect the inside of the intestine, things such as food or other drugs. Particularly aluminum-containing antacids, some calcium preparations, or iron. Okay, these are drugs that are known to affect absorption of T4, as well as the presence of intestinal flora. Now, absorption orally, T4 is good. It's about 80%. For T3 it's even better, but usually we don't, T3 isn't given orally unless there's a kind of rare exception because it's much more pharmacologically potent than T4. So usually most patients will be given T4, but there are still some situations in severe hypothyroidism where a patient may be given T3, but it's relatively rare now. So think oral absorption, think good oral absorption, think that certain things can affect the absorption of food, certain drugs, presence of bacteria in the intestine, and that can be affected by, like if the patient takes antibiotic or something such as this. Consider these factors when you consider giving back thyroid hormone to a patient. And also remember that if a patient is severely hypothyroid, and this might be more rare now than in days past because now there's routine physicals that are going to look at thyroid hormone levels in the blood and such. But it's been observed that severe hypothyroid patients may have impaired absorption of these drugs. And so that can affect the pharmacological action. Might have to wait longer for the drug to start working, or in some cases just go parenteral. But again, very rare these days. It would be surprising to see that, but not impossible. Again, when it comes to the half-life of T4 and T3, it's about a week to 10 days or so for T4. It's about a day for T3. But depending on the status of the thyroid at the time therapy is initiated, there can be effects that are a little bit varied from these half-lives. So for example, in a patient with hyperthyroidism, the metabolic clearances of these hormones will be increased. The half-lives will be less than you'd predict than with a patient with hypothyroidism, where the half-lives might be longer than you'd predict, particularly in the beginning of treatment. And then there are enzymes that can be induced in the liver by certain drugs that would affect the metabolism of T4 and T3. Enzymes, P450s, that can be induced by things such as rifampin or phenobarbital or phenytoin or carbamazepine. Now, this is a schematic representation of the TSH receptor. Do you remember where that receptor is? Is that receptor in the pituitary gland? No, right? It's in the thyroid gland. Remember, this is the receptor that's going to activate thyroid cells to produce thyroid hormone. And as you can see, this is a 7-transmembrane spanning G protein coupled receptor. Okay, it's got an extracellular portion, a transmembrane spanning region, an intracellular portion. And in this particular figure, we have certain amino acids within the receptor highlighted in red with white letters, representing different mutations in the receptor that are known to exist that can actually activate the receptor. So we talk about Graves' disease as an antibody binding and activating the receptor, and the thyroid becoming hyperactive. Or we talk about the receptor being stimulated by TSH. But there are also certain mutations which can actually activate the receptor. These are relatively rare mutations, but they present symptoms such as, similar to Graves' disease. So here in this example, we've got serine 281, and when this serine 281 is mutated, the receptor can just be constitutively on. The thyroid could be working really hard, even in the absence of any signal from the anterior pituitary. Okay, are those very common mutations? No, but I thought it's worth mentioning them, just to illustrate the point that the receptor, when active, is going to drive the thyroid to produce thyroid hormone. So, with respect to the thyroid gland, it regulates its uptake of iodide and its rate of thyroid hormone synthesis by intrathyroidal mechanisms, which are independent of TSH. The mechanisms are primarily related to the levels of iodine in the blood. Large doses of iodine will inhibit, for example, iodide organification. And there are certain disease states where this can result in the inhibition of thyroid synthesis in hypothyroidism, particularly a type of hypothyroidism caused by Hashimoto's thyroiditis. In fact, there are abnormal thyroid stimulators, we mentioned them, in Graves' disease. An antibody is produced called the TSH receptor antibody, which binds and stimulates the TSH receptor. In other words, it acts like a TSH mimic. It will bind the receptor in the thyroid and turn the gland on exactly in the same way as TSH would. But one big exception is that this antibody's actions last much longer than that of the endogenous TSH. So the Graves' disease antibody is a longer acting compound than the natural TSH from the anterior pituitary. The mechanism of action of thyroid hormone involves the actual free form of the T3 or the T4, leaving the thyroid binding protein, right, thyroid binding globulin, and entering the cell by diffusion, perhaps by active transport, but most likely by diffusion. When that thyroid hormone gets to the cell, within the cell it can be converted to T3 if it hasn't yet already been so, through the action of 5' deiodinase. And that T3 will enter the nucleus now, where it will bind to a T3 receptor. We know that that T3 receptor is a member of a family of receptors that are homologous with the C-ERB oncogene. Other members of the family include the steroid hormone receptors and the receptors for vitamin A and D. And we know that the T3 receptor exists in two forms, in the T3 receptor alpha and T3 receptor beta. So most of the effects of thyroid hormone on metabolic processes appear to be mediated through the action of these nuclear receptors. And as those receptors become active and they drive gene transcription, we see the formation ultimately of protein. There are many downstream proteins which can be upregulated by thyroid hormone. One example would be the increased formation of the sodium potassium ATPase, which leads to an increase in ATP turnover and oxygen consumption, and may be responsible for the calorigenic effect of thyroid hormone. This is also consistent with the observation that the action of thyroxine takes several hours or days to work before, after it's been administered. There's a large number of thyroid hormone receptors found throughout the body, in places such as the brain, the liver, the kidney, the heart, skeletal muscle, lung, intestine. There's a few tissues that are not particularly responsive, such as the spleen and the testes, but even the brain has receptors for thyroid hormone. If you look to the right, what you see here is micrographs of a Purkinje cell in the brain of a rat. The rat was made hypothyroid by giving an anti-thyroid drug. The rat on the right compared to the rat on the left. So if you look at the normal control rat, you can see the Purkinje cell with lots of dendritic branches. In the hypothyroid rat, those branches are much fewer. They're atrophied, they're smaller, and this is a significant effect on brain development. So thyroid hormone has receptors all throughout the body, and making sure those receptors get activated when they need to will ensure overall health in the patient. Now it's important to realize that T4 also can bind to the T3 receptor, but it doesn't usually do so. Its affinity is about 10 times less for the receptor than that of T3. So again, T3, the active form, usually going to be produced in the blood through the conversion of T4 to T3. We're going to bind to receptors. There are many thyroid hormone receptors throughout the body, and those receptors are going to help maintain cellular energy balance. The patient who will be given thyroid hormone replacement is going to be the patient who is deficient in thyroid hormone, the hypothyroid patient. And in the hypothyroid patient, we worry about many factors. We worry about growth and development, and are the body tissues functioning well, and are they being maintained? In terms of development, the thyroid hormone is critical for nervous, skeletal, reproductive tissue. It's going to be a transcriptional activation mechanism, meaning thyroid hormone is going to activate DNA transcription, and that DNA is going to be transcribed into mRNA and into protein. And so thyroid hormone is going to actually activate protein synthesis. It's also able to potentiate the secretion and the action of growth hormone. been found that in early life, excuse me, lacking thyroid hormone can cause irreversible mental retardation and dwarfism. And the dwarfism side comes in with respect to effects on tissue growth, but also in conjunction with growth hormones action. We know that thyroid hormone has effect not only on growth but on calorigenesis, and that's going to also be accompanied by a strong influence on metabolism of drugs, as well as metabolism of carbs, fats, proteins, and vitamins. So the secretion and degradation rates of virtually all other hormones, including catecholamines and cortisol and the sex steroids and insulin, are all affected by thyroid hormone. Thyroid hormone has multiple types of effects in the body, and very different effects throughout different tissues and organs. We see elevated rates of oxygen consumption and energy consumption. In children, this can cause a rise in body temperature. We see effects on the heart. Remember, thyroid hormone actually sensitizes the myocardium to adrenergic stimuli. So we can see increased heart rate and force of contraction, effects on blood pressure. And again, that goes along with that increase to sensitivity to sympathetic stimulation. Thyroid hormone is going to affect the respiratory centers to help them maintain normal sensitivity to changes in oxygen and carbon dioxide. Effects on the stimulation of red blood cell formation, which also contributes to the delivery of oxygen, because the red blood cells, the RBCs, bring that oxygen to deep within the tissues of the body. Effects on other endocrine tissues, effects on the bone. We know thyroid hormone affects the turnover of minerals in bone, and so on. In fact, the next several slides really kind of break down the effects of thyroid hormone in different vital organs and tissues. And the way that that's done here is in the context of hyperthyroidism versus hypothyroidism. So hyper, too much thyroid hormone, that's sometimes referred to as a condition called thyrotoxicosis, versus hypothyroidism, not enough thyroid hormone. And if you look across the body, we point to the skin. There's definitely effects on the skin. In hyperthyroid state, skin will be warm, moist, patient may be sweating, they might have fine and thin hair, something called plumber's nails. Oftentimes they'll exhibit pretibial dermopathies, and particularly this is observed in Graves' disease patients. While in hypothyroid patients, the skin is usually pale and cool. It could be puffy. The patients will have brittle hair and nails. If we look at the eyes, this is often easy to spot effect of too much thyroid hormone. There tends to be something called exophthalmos. The eyes look wide and big and open, and the upper lids retract. Sometimes it's referred to as wide stare. Sometimes it can be double vision, or periorbital edema around the eye. On the other hand, in hypothyroidism, patient can exhibit droopy eyelids, large tongue, puffy face. This, in a situation of severe hypo, or not enough thyroid hormone. If we look at the heart, in hyperthyroidism, we see decreased peripheral resistance, increased cardiac output, stroke volume, heart rate, pulse pressure. All of these are very important because they can lead to cardiotoxicity in a situation where there's too much thyroid hormone. On the other hand, when there's not enough thyroid hormone, we see increased peripheral resistance, decreased cardiac output, stroke volume, heart rate, and pulse pressure. And so we see the opposite effect on the heart. So clearly, the heart is a thyroid hormone sensitive organ. Thyrotoxicosis can affect the respiratory system, causing dyspnea and reduced vital capacity, while hypothyroidism can cause hypoventilation, as well as pleural effusions. GI effects, increased appetite in thyrotoxicosis, decreased appetite in hypothyroidism, increased bowel movements in thyrotoxicosis, decreased bowel movements in hypothyroidism. CNS effects, thyrotoxicosis, nervousness, hyperkinesia, emotional states can change. In hypothyroidism, we can see, lethargy, neuropathy. In terms of musculoskeletal effects, thyrotoxicosis, weakness, fatigue, hypercalcemia, effects on bone mineralization, osteoporosis, can affect the deep tendon reflex, increase it. While in hypothyroidism, we see muscle fatigue, reduced deep tendon reflex, increased alkaline phosphatase, LDH, AST. All of these are signs of effects of thyroid hormone on various physiological systems. Moving on, effects in the kidney, thyrotoxicosis, increased renal blood flow, hypothyroidism, decreased renal blood flow. We could basically read through the list. Hematopoietic effects, increased erythropoiesis in the hyperthyroid patient, decreased erythropoiesis in the hypothyroid patient. Reproductive toxicities in the hyperthyroid patient, enhanced gonadal steroid metabolism. In the hypothyroid patient, we see the opposite. Metabolic effects are numerous. In the hyperthyroid patient, increased basal rate, negative nitrogen balance, and protein catabolism. Hyperglycemia can occur. Increased free fatty acids, decreased cholesterol, all kinds of effects on lipids, increased requirement for fat and water-soluble vitamins, and enhanced metabolism of drugs. While in the hypothyroid patient, we tend to see the opposite. We see decreased basal rate, delayed insulin degradation, increased insulin sensitivity, effects on cholesterol, opposite to what we saw in hyperthyroidism. Here we see enhanced cholesterol and triglycerides, and so on. So hopefully what you've seen, through the last 3 slides or so, is that either having too much thyroid hormone or not having enough thyroid hormone can cause serious problems to patients. And that's why there's a great desire to make sure the thyroid hormone levels are what they should be in patients.